I am Dr. Morgan Schuster, a sports medicine physician, and today we're going to go over the knee exam. The next step in observation actually is looking at the knee, observing if there's any bruising, any swelling, and or any deformities or changes in the skin. The next is a palpation, and in that I actually start off with the bony landmarks. So actually palpating onto patella, seeing if there's any tenderness or pain actually on the patella bone. And then you have to remember the other bony aspects are actually the tibia, which are down into this area. And then also above is the femur, which is sometimes a little bit harder to palpate as well due to the quadriceps muscle. And then actually palpating soft tissues, which I will start up here with the quadriceps muscle. Remember that is superior to the kneecap. And then actually into the medial aspect, in which you have your joint line. You also have your MCL that comes along in this aspect down to the tibia. Actually then coming down and around to the inferior aspect of the patella, and then actually coming down onto the anterior knee at the inferior aspect. Then actually palpating over to the lateral knee, in which you have the LCL in this area. And just to note that your ACL is actually in the anterior area of your knee, although it is hard to palpate in this position. So the next aspect is range of motion. Actually, the first thing I do is actually ask the patient to lift their leg and actually bend their knee. And as you can notice, this is at 130 degrees. Some patients you can actually get to 135 degrees, and then actually to extend their knee and actually place it down and back onto the table. And here, this is at 0 degrees. So normal range of motion is 0 to 130. And then you can actually sometimes get them to like a -5. If they're not able to do a full range of motion, then what I will do is actually do passive range of motion. So I actually have them start to lift their knee, and then I will actually try to bend them as much as I can and seeing for a passive range of motion. Then, as I said, when they're in this position, I actually then go ahead and I test for the joint line. So you just have to remember that the joint line is between the patella and also between the tibia, all right? So, but you're going to end to the femur. So patella is right here, femur, and tibia. So what I do is I'll actually palpate along the joint line. And one of the things you need to remember is that it's not only just here in the center, but palpating along the whole entire joint line down this way. And then I will do it actually on the lateral aspect also in this fashion, just like I did on the medial. The important thing about this is you actually want to do palpating the joint line actually in this position. The other thing I will do also is actually palpating for the tibia and seeing if they have any, palpating for the tibia and also for the patella tendon, seeing if they have any tenderness. And then what I do is actually come down, bring them down to 30 degrees, and here you can hold their leg, all right? And then I'll actually test for MCL, which is the ligament here on the medial collateral ligament, and I'll actually test them. And sometimes if you have a bigger patient and you have small hands or a smaller body, you might need to use your body a little bit more. So actually we'll get into this position, put them at 30 degrees, and then actually what I'm doing is actually moving this foot out and then stressing out what would be MCL. You're going to look for any laxity that might be in that area, and also if they have any pain. And then I would actually go ahead and I would then repeat this again in this fashion for lateral collateral. So I'm actually pushing this way and then pushing the lower foot into the medial aspect. And then, as I said, when I have them in this position, the other thing I will do is actually then to go ahead and test for Lachman's. If you have big hands, and then you can actually, you'll see a lot of providers actually go ahead, and what you're trying to do is you're actually trying to bring the tibia and you're pushing that forward as you're pushing down the femur to see if you have any laxity in this area below the patella. So sometimes it's really hard. So another thing you can do, because this has to be done at 30 degrees, is actually put your knee underneath their knee, put it at, so you're at a 30-degree angle, and then you can actually do the same motion, but now you're actually not having to hold that knee in a 30-degree angle. And again, you're looking for any laxity or translocation in this area right here. So he has none. And then the next thing is also McMurray's test, which is for meniscus. So what you do is you actually have him in this position, and what a positive test for McMurray's is actually a painful click. So you want to test the medial aspect first, and what I do is have him in this position. You're actually going to rotate their foot to the medial aspect, and then trying to squeeze or trying to put a lot of pressure into the medial aspect while I'm actually also rotating. I actually have my hands on their patella to see if I do feel any type of click. And then the lateral aspect is this in this fashion also. While the knee is in this position, a couple of the things that you can do is actually test for any laxity of the patella, and that would be actually moving the patella from side to side. If the patella is able to move more than a third from its position, then that constitutes some patella laxity. And the same thing with if someone's prone to this patella dislocations, when you actually go to push that patella, they're going to complain of apprehension and not wanting you to do that. Another aspect is actually to grind onto the patella. Some patients do have some patella issues, to include patellofemoral syndrome, and sometimes if you actually push onto different areas of patella, they will actually have pain, and actually sometimes you can feel some crepitus. Another test for patellofemoral is also if you actually push onto their patella and then you have them contract the quad, and a positive test is actually pain. Another thing for patellofemoral syndrome is actually looking to see if the patella lines in the same plane and position as the tibia. You might find that it might not line up as well. Some providers will do Q angles. I actually just like to have them like this and seeing if I can see if my patella is lining up into this aspect of the over the tibia. The other thing is you can also test for a posterior cruciate ligament tears. Most patients do not have them, but the test that I tend to use is actually having them flex to this position here, and then actually taking their tibia and then actually trying to push posteriorly to see if you have any laxity in the PCL region. There are other tests for the PCL, although those are more difficult to do in a patient that is not sedated at that time. Another test is a Thestley test, which actually tests for meniscal pain and also for a possible of a meniscal tear. So you might see this listed as a dancing test also. You actually have the patient grab your hands. So you grab my hands, and then what you do is we're going to be testing the right knee. So you have them stand on that leg, singly, and then actually bend their knee to about 30 degrees. Have them stand right there. And then what we're going to do is you ask the patient to go ahead and twist onto your knee. So twist inwardly on your knee, and now twist out. And then you ask them if they have any pain when they are actually doing this test. If they have pain, that is a positive test This concludes the knee exam. Again, just remember to develop your own system of how you want to do the knee exam to include all the important aspects of the exam with a special test.